So welcome everybody. Thank you so much for taking time of your day to join us in this panel for Farmworkers during the COVID-19 pandemic. My name is Jose Ibarra. The organization that I represent today is the NC Farmworkers Project. A little bit about me. Born in Oregon, raised in North Carolina. I was first exposed to the farm worker movement in high school, my freshman year in high school, when I joined the Student Action with Farmworkers Levante Leadership Institute. Years later in college, I had the privilege to do the summer program where I interned, where I'm currently working at today, straight out of college. We're currently working with COVID-19 testing, as well as also helping with the vaccine distribution in Southeastern North Carolina. A little bit about the organization. We're a nonprofit organization that originally was founded on more organizing and advocacy for farm workers. Over the years, we've slowly transitioned into more health advocacy and access to medical services for the farm worker population. As you can see, one of our prime principles is empowerment. We like to give the worker a platform to, we take into account the workers' feelings and consider all aspects of farm workers. So our learning objectives today will be emphasizing mostly the barriers that we've encountered during the COVID-19 testing initiative, as well as some solutions and strategies that we used that have helped in testing. It hasn't been very clear cut, but it's been an improvement with some of these strategies that you guys will learn about today. And now here we have a little fun activity for everybody. Our Icebreaker will be a word cloud. This does not require any downloading any app. It's very simple. So I'll be doing it with you guys just to walk you through the process. I also included the instructions on screen. So I want everybody that can go to polleverywhere.com. It can be on your phone, it can be on your laptop or your a tablet. It doesn't matter. Once you go to pollev.com, it will ask you for a username. You can just type in Jose Ibarra 779 for the username. Okay, so on screen, you should see a question that comes up. What words comes to mind when you think of your experiences during COVID-19? So it's really impossible to really encompass all your diverse and rich experiences that you've had this past year. But if you had to, just like you are now, if you had to choose a word or even a phrase, what would it be? I'm gonna let people the audience members put in their responses. And the way that these word clouds work, for those who are not familiar, the bigger words tend to be the most common words used. Okay. The only limiting thing is that I have the basic version, which only allows up to 25 responses. But I wish it was bigger, just so I can get more responses. But already we're seeing stressful, we're seeing fear, illness, privilege. These are very, very, characteristic of the pandemic during this time, that people have lost work. People haven't been as lucky with sickness and being isolated or even worse, ending up in the hospital. There's been a lot of negativity. And most of these words are pretty negative when I take a look at them. Humbled, terrifying. Okay. So now we're going to move on to other responses from a different audience. For those who are wondering, it's the farm worker responses. During my time as an outreach worker, as a community health worker, I've had the privilege and honor to visit a lot of these camps. And during these conversations, these chat that I have with workers, I've asked the workers the same questions. And here we have familia. And this word it's a beautiful word, because workers I mean, they spend half of the year back home, and the other half, specifically the H-2A workers, spend the other half this here in North Carolina. And that's a big sacrifice when it comes to being separated with family. And we hear hermanos. I'm sure workers have heard it so many times. It's like learning about different hand hygiene techniques. And we have agradecido, and which that basically means grateful. So I don't see as much like compared to the today's audience, which is a lot of like scary words, a lot of like negative words. Here we have much less of that, and you can really compare and contrast the differences. Farm workers in North Carolina, each year we have approximately 150,000 workers and their dependents. We have many H-2A workers, but we also service nursery and greenhouse workers. Nursery workers tend to be more permanent, have more permanent residence, whereas H-2A workers are more in congregate living arrangements. Some of the most common crops that are harvested each year are sweet potatoes, tobacco, and we have Christmas trees in the West. Some of the work that we're currently doing on the ground right now, we're using anterior nair swabs as well as COVID-19 antigen with the rapid testing. We're using it in conjunction just to avoid a lot of the false negatives that the rapid antigen test, the Abbott test does. We really focus a lot of our efforts in the educational presentations early on, just because we saw a lot of testing hesitancy when it came to testing. So, focusing on what is COVID-19, why is it important to test? And even today, we're focusing a lot of our efforts on the vaccine distribution and vaccine hesitancy as well. So this is the data that we got from our end, our nonprofit organizations end. Overall, we were able to test over 30 plus camps and nurseries. And from this data alone, when you look at it, it's about a 20% positivity rate as compared to the North Carolina average, which is much, much less. This can be attributed to the congregate living arrangements that a lot of H-2A workers in the camps live in. From the ones that we visited, it can range from 5 workers to 15, 20 workers. And a lot of times that if there's a symptomatic sick worker, just due to the nature of COVID-19 and its high transmission rate, we assume that others are exposed. And here I included a definition from the CDC on the cluster. A COVID-19 cluster is defined as 2 or more confirmed or probable cases among farm workers within a 14-day period. All in all, we were able to identify and work with 18 clusters within camps and nurseries. Even before the pandemic, we've encountered a lot of factors, a lot of social determinants that really made it difficult for farm workers to access healthcare services in general. The most common ones, as you can see, are the transportation and the farm worker working hours. Farm workers work very early from 5 a.m. to 5 p.m. And during these times, our local clinics usually run from 8 a.m. to 5 p.m. So by the time that workers are actually coming home, they can really drive straight to a clinic, even if they did have transportation. And then during COVID-19, these factors grew exponentially. We have those, and we have some new ones that we encountered, which were a lot of growers don't want to lose the workforce. I had conversations through phone or in person in which I was offering COVID-19 testing to their workers that had just arrived or in the future as well, just to have something planned out. A lot of growers, some of the response that I got were what would happen if they test positive? Who's going to do the work around here? And it's just not the workers either. I mean, it's not just the growers as well. It's also the workers. The workers have a fear of being sent back home. Some of the things we heard were also like losing work and therefore losing pay. I mentioned earlier that workers are spending half the year back home, and then they're doing the sacrifice to be separated from their families for another half a year, just to lose more working hours. So in the farm workers' terms, time is precious. Their time is precious. And then we have a stigma. Whenever a worker was symptomatic and they would call us or they would seek testing, like at really late hours, like 5 or 6 p.m. We would go out and test, and we would offer the other workers, because we talked about how it could be potentially they could have been potentially exposed, and sometimes workers might react a little negative towards the worker that invited us, just because they don't want to they don't want to be tested sometimes, or even if they do end up sick, they might blame the worker that was originally that had originally tested positive. So there's a lot of like factors that go into play when it comes to COVID-19 testing. I also included fear of the unknown, and basically what I mean is that there's so much more. I could talk about this for a long time, but there's just so much going on the ground that that includes rumors, concerns, and things as such. I included three quotes here about testing. I'm going to talk about the first one, and maybe the second one as well. Here, I include them in Spanish, exactly how the workers said them. The first one is, is it true that if I come out positive, I'll be taken back home? And that goes along with what I said earlier, how workers themselves don't want to. They fear losing work. They might even fear coming back the next year, or being ignored for another worker to be brought here for work. And the second one is very scary. So just to warn you in advance. This one's where a worker said that he had heard that another worker from another camp was burned at the hospital after testing positive. And this was really early on in the pandemic when we went out to the camps, and these are the things that we were hearing. It became very apparent that we had to focus really much on the informational, the charlas, the conversations in the camps, and going forward to now, I think it's also good to include concerns about the vaccine that we've heard. I'll talk about the first one. This one was at a nursery, and I talked to this lady, and she said after one of her presentations during their lunchtime, she said that I heard that the vaccine was made using fetal cells, and because me and my family are against abortion, I or my family will not be getting vaccinated. And these are very, like, we hear these like all the time. We hear new ones mostly every week. Sometimes we don't have the answer to these. We can't just say no, you're wrong, because that's not the way we like to approach these subjects. We like to empower. We like to listen. What we do is that we go back, we regroup, and we talk to the state. What kind of recommendations can we get? Just how we've done with the questions about allergies. Even though we might not know it initially, we go back and regroup and bring the correct information to the workers themselves, just to address vaccine hesitancy. I included some pictures about me and my coworkers. The top picture is actually a nursery, and the bottom picture is an H2A camp, doing some informational presentations. And we talked about a lot of the negative barriers, but let's talk about the strategies that we've employed in doing outreach. I talked about the on-site presentations that were really targeted towards getting rid of the fear, the stigma towards the testing, as well as coming up positive. And how we talked about how there's workers, they don't want to quarantine, they don't want to test because they lose work. How do we address some of these? Even though it doesn't fix everything, financial supports have proved to be to alleviate some of the damage done by the pandemic for the farm workers. We have food banks. Just because whenever farm workers do test positive, they have to. The recommendation is staying home, quarantining away from public, and isolating away from the others who are not positive. Having food banks and food donations readily available, can help alleviate a little bit. They don't have to worry as much about going out on the weekends. The workers don't go out as much anyways, but if it's on the weekend, Friday or Thursday or Friday they tested positive, food banks do alleviate a little bit of the damage. And we work closely with growers, work with the workers and the growers. We come up with a recommendation. We come up with a plan based on the recommendations from the state and the local health departments, such as finding alternative housing or finding alternatives to isolating the positive worker or workers. Like I said earlier, empowerment is a very big part of our organization. We talk to we take into account the growers and the workers. We have this thing called a growers and workers guide to COVID-19 testing. This in Spanish and in English, designed by the state to really kind of give the grower a good understanding of the process. What does it mean when one of your workers comes out positive? What's the difference between quarantine and isolation? We found that presenting this to the grower and worker early on, even before testing, it makes the whole process much easier, much smoother, and we're able to work with the positive worker and isolate them as quickly as possible. And I think it's also important to understand, like, I think real empowerment is understanding like the worker side. These farm workers don't see themselves as victims. Farm workers are people. They see themselves as grown men who came here to work, and it's important to understand that. So we have these conversations, and we're there to provide the information for the farm worker and help as much as we can, but without crossing that line of we're here to save you, or we're here to rescue you, because it's not like that. And here we're talking about the another one of our learning objectives, which a lot of this work wouldn't have been possible without many of these organizations. And there's so many more partnerships that we made throughout the year, and like mobile clinics, local clinics that came out to help with testing. And I can go on and on, but the rural health program, which is part of the North Carolina Department of Health and Human Services, and their COVID-19 response coordinators, they've been a tremendous help with helping with PPE donations. We were able to come together and make these we call them the COVID kits, which had like 2 cloth masks, 5 disposable masks. We had the guidance for the growers and the workers. We had the recommendations for isolating and quarantining, and overall, just a great support system. I think it's really important to have collaboration and communication to be able to make these things work. We had the Episcopal Farmworker Ministry, which really helped with the emergency funds, as well as the food donations, culturally appropriate food donations for the farm worker population. Working closely with local health departments, I included two departments here, but honestly, any of the 8 counties that we serve, we work closely with counties, and really connecting the contact tracers with the workers themselves. Just because it makes the whole process much easier. I can give my recommendations, but we have the local department also giving the, more personal, more intimate recommendations for COVID-19. And we also have Southeastern Health and Benson Area Medical Center. A lot of the testing materials, the PPE, and all this work wouldn't have been possible without them in the picture. I'm also happy to announce that to this day, we're actually working very fast and all over the southeastern North Carolina with the vaccine distribution. We're working with growers, we're working with farm workers, and compared to testing, we're seeing a big positive response to the vaccine. We haven't seen as much vaccine hesitancy as we thought we were going to see. And I think a big part of this because a lot of workers and a lot of growers just went through a lot of frustration with the transmission rates of COVID-19. And I think from a lot of you guys' perspective, from your responses that you gave early on, it can be a very frustrating time for everybody. I think, growers and workers are just happy to, receive the vaccine and, get out of this pandemic as soon as possible. But that's what I have for you today. Thank you so much for giving me a platform to speak on my perspective as a community health worker, as an outreach worker. I hope some of you were able to learn some of the work that was being done on the ground. And I open the floor to anybody that has any questions, anything about any of the work that we did and continue to do. If you don't have a question now, you can also ask me at the end of the panel presentation.
So somebody does have a question. Emilia Sanchez asks, could you expand more on the financial support you mentioned in the solution? Like if you had enough funding, how would that be distributed to better help farm workers and their project?
That's a great question. So in late February, a lot of the funding was depleted. I was in direct communication with a lot of the vendors that provided the emergency funds for farm workers and in the community as a whole as well. There was a lot of like backlog. There was just a lot of applications that were being turned in from all over North Carolina, and just because of that, a lot of farm workers weren't able to receive any of the financial supports. I think, like I said, that does alleviate a lot of the barriers that come along with COVID-19, because COVID-19 testing isn't just testing and then that's it. It also is a wraparound. You have to follow up with every patient, how they're doing. How can you make the whole process much better as an outreach worker and as a community health worker? So having funds maybe more spread out, not just in one organization or two organizations, but having more organizations providing the same financial supports, just to avoid that backlog in applications. Thank you.
Thank you, Jose. And then our next speakers will be Hannah and Lisa.
Thank you. Thanks, Jose, for that really wonderful presentation. I'm going to pull my PowerPoint up here. And so welcome again, everyone. Good afternoon. It's so wonderful to be here with you all. My name is Hannah Miller, and I'm a program manager and community health worker with the Maine Mobile Health Program. I'm here today with Lisa Tapert, who's our CEO, to talk about universal COVID-19 testing for incoming migrant farm workers in Maine. As I said, as I started, but I just want to take a moment again to say thank you for being here. 2020 was a really hard year for all of us, and I'm grateful to be here with you today. And so to start off, the objectives for our presentation are to understand Maine's multi-partner model for rapid COVID-19 testing for farm workers, to describe the importance of and strategies for addressing housing and other wraparound services before and after testing, and to help identify strategies that can improve current testing programs and can be applied to vaccination programs. First, a little bit about us. Maine Mobile Health Program is an all-mobile federally qualified health center with a specialty focus on farm workers and seafood processors. We are the only health center with this designation in the state of Maine. 78% of our patients are best served in a language other than English, specifically Spanish, Haitian Creole, and Patois. Our program is centered around the community health worker model. Most of our staff are CHWs who focus on care coordination, interpretation, transportation, and health education through our direct services and voucher care. In 2020, we added education, prevention, testing, and vaccination for COVID-19 to the list. The photo on this slide here is one of our mobile units. Our presentation today will focus on the universal testing model we created to support our incoming migrant farm workers. Maine has a somewhat unique harvest season where most of our migrant workers arrive in July or later. This natural delay, paired with the slower arrival of COVID-19 in Maine, offered us several months to prepare compared to similar programs in other states who were forced to immediately respond to outbreaks. Late last spring, growers started to contact us asking for advice. Lisa worked with partner agencies to advocate for farm worker protections at the state level and push the governor's office, DHHS, and the Maine CDC, that's what we call our state public health department, to include farm workers in their plans. She also partnered with the Maine Department of Agriculture and one of Maine's biggest workers' compensation insurance companies to offer safety webinars for growers. Lisa spent a lot of time on the phone listening to growers' questions and addressing their concerns. During this early outreach, we detected the need to offer universal testing for workers when they arrived. We identified 4 key elements to this plan: sick leave, rapid testing, hotel space for isolation and quarantine, and patient-centered education. Before agreeing to test our workers, Lisa coached each grower and contractor about the importance of providing sick pay and the reimbursements available to them through the CARES Act. This often involved conversations or multiple conversations, and in the end, only a couple refused to offer sick pay. Maine also struggled with offering sufficient testing to meet the demand. There were not enough testing sites, and results were often delayed by 2 to 3 days. Based on what we all know about migrant workers traveling in groups, living in congregate housing, and working closely together, we decided we could not depend on the state-sponsored testing sites to meet our needs. We borrowed 2 Abbott ID Now machines from the Maine CDC and purchased a third to allow us to develop a rapid universal testing program. During our first preseason event using the machine, we learned that the Abbott is sensitive to moisture and requires a mobile unit or other indoor space to operate properly. This information was key to the development of our testing model. During the planning stage, we also identified the importance of providing a space for isolation and quarantine. Many of our growers had inadequate room within their housing to provide a safe and comfortable space for someone who tested positive and their close contacts. Lisa coordinated with Maine Housing, Maine CDC, and Mano a Mano, a community-based organization, among others, to provide hotel rooms and other wraparound services for this purpose. During the first phase of testing, we also realized that some workers needed a place to stay before accessing testing. Growers were not letting workers onto their property without a negative result, and we worked with our partners to address this barrier. Lisa will talk more about this piece in a moment. Our migrant workers mostly arrive in 3 big waves: midsummer, early fall, and late fall. For the first phase of testing, we decided to adapt our mobile services model into a testing environment, which is what you can see pictured here. This allowed us to travel to work sites and other designated locations to offer testing. To limit the volume of people coming on and off the unit, we purchased pop-up tents to create shade and allow for better airflow. Each worker would sit with a community health worker for registration, move to the provider station for a swab, and move to a final tent to wait for their results. Before each testing clinic, our staff would refresh the stock of clinical supplies, including PPE, Abbott test kits, and cleaning products. They also made sure to have ample supply of support materials for workers. These included bottled water, surgical masks to use while testing, cloth masks to take home, and resource bags with materials on topics like COVID-19 prevention, legal and immigration services, and education. Our first clinics occurred during the hottest days of summer, requiring staff to work outside in 90-degree heat. For many of you, this is your normal, but in Maine, we were quickly wishing for cooler weather. As we developed and adapted our testing model, we continued to hold the patient experience at the center. At first, we focused heavily on the individual experience. How do we provide a private, confidential space for workers to ask questions and give informed consent? We focused much of the registration process on what we called pre-test counseling. In other words, health education on COVID-19 in general, what our test is like, and what the results mean. We thoroughly explained the consent process, including consent for the test itself and consent to share the results with the Maine CDC. We included a separate consent form asking for consent to share the results, if positive, with the grower in order to guarantee or attempt to guarantee their access to sick pay and other supports. A sample of all of these materials is available on the CVent platform. Please reach out to us if you would like a copy of the translations in Spanish or Haitian Creole. We realized that our focus on the individual during this first phase inadvertently caused fear and uncertainty for many folks waiting for a test. We originally relied on the growers to explain the testing requirements before their workers arrived and quickly learned that it was often not happening. This resulted in confusion and fear related to the test itself, as well as concerns about what would happen if someone tested positive. During our second phase of testing, we continue to use our mobile testing model, but with an updated education strategy. We started with a short group education session to better explain the testing process, the the test itself, and isolation and quarantine, and answer any questions. Although not perfect, this seemed to work better. In September, we decided that our original model for testing would not work for our migrant workers arriving in the late fall. The weather would be too cold to ask folks to wait outside. We also wondered if our mobile model at the work sites was limiting a worker's ability to truly give informed consent. For this third phase, Lisa helped us identify a hotel with an empty ballroom that was already being used to support people in isolation and quarantine. This hotel was ideal because most of our workers would need to pass through this area naturally when traveling up to Maine to work. We decided to offer workers testing all in one location before they moved on to their housing. Focusing on the lessons learned from phases 1 and 2, we centered our planning for the one-site testing environment on the worker experience. What should they know before traveling to Maine? What would the waiting and testing experience be like? And what happens when someone tests positive? For pre-arrival, we worked with Mano a Mano, a community-based organization, on a video to explain the testing requirements, options for sick pay, and the possibility of isolation or quarantine. This was shared with workers and contractors during the weeks before their arrival. We also spent a lot of time thinking through the layout. When touring the hotel, we decided to use a large ballroom for testing and a side room for results. There was not enough room inside for workers to wait before their test or for their crew to finish. As you can see in the pictures here, we and our partners provided chairs with enough space for social distancing and outdoor bathrooms. Mano a Mano also coordinated coffee, fruit, and other culturally relevant food to help folks feel welcome and supported throughout the waiting process. For this third phase, we updated our pre-test counseling again. This time we continued the model from phase 2, where we started with education for a small group of workers. Folks knew more about COVID-19 compared to the summer, but many had never accessed testing before. We focused heavily on what our test was like and the possibilities for isolation or quarantine. Finally, we concentrated specifically on the results process. During phases 1 and 2, staff continued to express concerns about the experience for people who tested positive. For one, how do you make sure someone who tests positive is not automatically outed based on our workflow? And 2, how do we make sure to address their needs in a timely manner? When operating outdoors, it was easy to separate someone who tested positive, but they were often visible to everyone else. They also had to wait a long time because our staff were the only ones equipped to safely transport people who tested positive. The hotel, in this case, offered an opportunity for us to fix both of these issues. We eliminated the need for transportation by organizing the testing at the same hotel where folks would isolate or quarantine. We also designated a side room at the hotel where folks would receive their results. Each worker received their results, negative or positive, away from everyone else. If they tested negative, they could get a flu shot or head back outside. We had organized public health nurses to come on site and provide flu shots for folks who wanted them. If the worker tested positive, they were offered a question and answer session with a nurse via telehealth and were able to stay in that same space until their room at the hotel was ready. Overall, this universal testing approach, first mobile and then at one site, was both labor intensive and successful. We spent countless hours upfront offering universal testing to our migrant workers, and as a result, spent much less time on outbreaks in the camps. Lisa is now going to talk more about the housing and support services piece and what strategies we can use as we plan for 2021.
Thank you, Hannah. Hannah talks about me doing different things in the the lead up to the testing that we did, but she was also very involved in the design of every step of this program. And I would say that having a couple of people who are really, really committed to figuring out how to do this right and who are willing to move forward in a different way than they started is really important. We had to admit, you know, when we had done well and when we hadn't done as well. And so for us, that was the iterative process, you know, meaning that we learned from the first, second, and third attempts at offering this testing. From the beginning, we also partnered with the Department of Health and Human Services and our public health department, along with Maine Housing. We had really lots and lots of meetings before the season started with those groups, and they committed to being engaged with us. We couldn't have really done this testing without them. I just wanted to say that incidentally, we tested over 1,300 people this year, and that's more than we actually usually have patients. We're a small program. We usually have between 900 and 1,300 patients. So in addition to our regular patients, we also did that many tests. As Hannah said, the staffing, some of it came from our organization, some of it was from our partners at Mano and Mano. We also did some contracting out for some of the swabbing and some of the symptom checking, and we used CARES funding for that support. We couldn't do everything ourselves. This was way more than what we were used to doing in our usual mobile clinic program. We're also a voucher program. As Hannah said, the sick pay was really important. It was important for us to convince the growers that that was essential if they were going to require testing of their incoming workers. What we weren't completely prepared for was how much people missed out on overtime pay if they were isolated or quarantined after testing positive or being exposed to somebody who tested positive. And so we were able to work with Mano and Mano to provide grants to those who were going to miss out on overtime in addition to the sick pay. Those were, you know, anywhere from a couple of $100 to $1,000, and they helped make up for the time that folks who were quarantined would have spent working overtime. As Hannah said, and as Jose talked about, the food was important for us and for that testing environment. Basically, we had 3 Abbott machines going at once, and we were able to test 70 people in one day. We didn't test every single day, so sometimes people had to wait a day or two in a hotel while they waited for our testing program to come to ramp up again. And that was when the on-arrival hotel was so helpful. When we first thought about the on-arrival hotel, which we knew was going to be necessary, our partners at Maine Housing weren't sure they could pay for that. And so we were in a position where we guaranteed that we would pay for those hotel rooms if they didn't get reimbursed by FEMA. And FEMA did end up reimbursing, but we had about $80,000 that we thought we might have to pay ourselves. And we were willing to do that, but it was a bit of a gamble for us. Next. So these are some of the signs that greeted workers who were coming into the testing environment, just to say that, you know, we really care about these people as individuals. We thank them for their labor, but we also appreciate them as human beings, as Jose said. And so we had a lot of posters up around the testing sites that were welcoming, that were in multiple languages. One of those languages is Haitian Creole, I think. Is that right? Yeah. That's our second language. Next. Yeah, so I think we learned that every time we think we have a patient-centered approach, we can do better next time. And so as we're moving into vaccination and testing at the same time, we're really trying to center the patient at the center of everything we do. We want to make sure that not just the labor contractors, not just the growers know what is going to be available, but that we're able to communicate with the workers themselves as much as possible before they come into Maine. There were some people who said if they had known they were going to have to be tested before they went into housing and were going to end up in a hotel, they wouldn't have come. And so if that is the case, if testing is going to be required this season, which we think it will be, we want to make sure that people know before they come to Maine that that is a possibility. So prior to vaccination, we've done a lot of listening sessions. We're also collecting information just when we do patient registration. Every person that we talk to, we use that information that we hear from them to develop our health education materials for the vaccination. We also learned that when you do a group event like we did, you really have to make it a pleasant and hospitable environment for folks. Sometimes we had a large group of people that were all either in the same transportation or in multiple transportation, multiple vans together, and they all waited for everybody to be tested. So we really had to make sure there was food for them and that it was a nice environment and that they could use facilities while they were waiting for their colleagues to be tested. We offered the flu shots at our testing site, and not very many people took us up on that. And so we were especially concerned about vaccine hesitancy. And we're still working through that. And what we've learned is that the best thing we can do to encourage people to feel comfortable with the vaccine is to show them pictures of the staff, community health worker staff that they know getting the vaccine, and really just have one-on-one conversations about that. I think I've talked enough about the growers, but they certainly were really wanting to work with us for the first time ever. We had something that they really needed. And so it was interesting helping them figure out how they could prepare to keep workers as safe as possible. And I think this time we're going to do less close collaboration with the growers and really develop our vaccination and our testing kind of separate from grower locations as much as possible. I think that's what I have to say. Yep. Thanks everybody for your time and attention. We're also happy to, you can always reach out to us afterwards.
Thank you, Hannah and Lisa. For the sake of time, we're going to continue with Dale, Jackie, and Audra.
Great, thank you. Good afternoon. I will share my screen and get us going. My name is Dale Freeman. I'm the Director of Migrant Affairs for Health and Human Services in Michigan. Also with me are Jackie Chandler from Michigan Primary Care Association and Audra Fuentes from the Office of Migrant Affairs. So we wanted to share a little bit about how we implemented migrant farm worker testing for COVID-19 in Michigan. Trying to advance my slide. There we go. So prior to the testing mandate, the testing mandate was in August. And what we were observing in that time period between mid-March and August was that we saw early COVID-19 outbreaks that impacted agricultural workers. Probably the first ones that we became aware of were in a few of the dairy farms that we have in the state. We've got a lot of dairy farms, but in particular, in a rural area in northern Michigan, without much connection with the healthcare services in their area. And so it was an issue where we needed to assemble people and agencies to help these workers who are testing positive. At about shortly thereafter, we also saw outbreaks in food processing, meat processing, and egg processors. So those were about the time when meat processing was making national headlines. It was being impacted here in Michigan as well. And then in addition, we were seeing this in egg processing, which is another big industry for us. And it started to underscore for us how workers living together and working together in close contact, and especially the egg processing workers, they were living in Lansing and traveling about 40 miles to a job in Ionia to work for the egg processing business. And they carpooled for those rides. And more and more, we saw this connection between living together, working together, and farm workers. Also, as workers would test positive, local health departments would be working to get other workers tested. And we saw quite large numbers of workers who were testing positive. And this occurred in nurseries, and it also occurred in asparagus producers. Asparagus is typically our first outdoor crop. So again, we're moving from year-round jobs like dairy and food processors and into early season jobs like nurseries, and then just a little bit later in asparagus. The intervention that we worked on was to establish community work groups in areas with large numbers of migrant farm workers and seasonal farm workers. These community work groups were composed of state agencies, like my agency, Health and Human Services, as well as the Agricultural Agency, which in our state is Department of Agriculture and Rural Development, as well as the Employment Agency, the Labor Agency, which is Labor and Economic Opportunity. In addition to these state agencies who could provide support for these farm workers, we had local health departments. In Michigan, I have not had much experience working with local health departments before this, and I learned along the way just how important they are for the work of COVID interventions. And then on top of that, we also worked with Michigan Primary Care Association and the FQHCs that they represent. Later on, as we started working on interventions for farm workers who were testing positive, we brought in community action agencies for a lot of the help that they could provide. Initially, our strategy was to encourage voluntary testing by providing free testing for agricultural workers and trying to work with employers to establish this voluntary testing. We encountered resistance. We encountered a lot of resistance from employers because they were really concerned about what they were going to find and what the impact was going to be on their business. We also saw resistance from employees who were not wanting to do it for a variety of reasons. One is the, just the very fact of the invasive procedure that a PCA test is, but also not wanting to do something if their employers were not in favor of them doing it, and also being concerned about what the impact of testing positive would be, since a positive test resulted in a person needing to be isolated. It was at this time in the voluntary testing phase that we also began tracking agricultural outbreaks. Prior to July, we didn't do that. There was no special category in our reporting, statewide reporting for agricultural outbreaks. And this helped to underscore what was being found and where it was being found. Given the results that we had from voluntary testing, we looked to provide a testing mandate. And for this, there were several aspects that were really important. Leadership was overwhelmingly important. For us, the director of the Department of Health and Human Services really saw agricultural workers as being particularly vulnerable and in need of protection. And so he wanted to do what was necessary to provide that protection for agricultural workers, as well as to ameliorate the impact of a positive diagnosis. My next bullet there, health and human services. I think it was about 2013 when our department, I'm a part of what used to be the Department of Human Services, was combined with the Department of Community Health. And so we don't have a long history of being one department, but we could not have done this, this mandate, this activity without working together with the health side of our department. Those health experts telling us, what would be needed in order to help identify workers who are potentially positive for coronavirus and how to set up this requirement. The next item is MDARD. MDARD is the agricultural department. We worked with them as well to help us to target how we could target this order to have the most impact for workers and somehow ameliorate the impact on small employers. The next item is nursing home order, and that is because we had a public health order that the state had that was the pattern for us for how to implement a requirement like this. So on August 3rd, the Director of Migrant Affairs, the Director of Health and Human Services issued this public health order for requiring mandatory testing for agricultural workers. It provided for a mechanism for paying for testing for employers, so they would not be required to pay for this themselves. Jackie is going to go into this further, but we partnered with Michigan Primary Care to provide this testing. And then the last item, we recognized that support was needed for positive agricultural workers. So regarding the testing requirement, what it was that it established baseline testing that needed to be completed for all of the identified areas by August 24th. So it was issued August 3rd and was baseline testing was expected to be completed by August 24th. This was a huge task and one that was not quite completed in that short period of time, but a lot of work went into getting it there and a lot of work went into making sure that we had all the baseline testing that we needed. It also required symptomatic testing. So any worker who was displaying COVID symptoms was also required to be tested. And then finally, it had a requirement for those that were newly arriving residents at migrant labor housing or newly arriving workers to be tested. And it's this aspect of it that continues to this day. So who does this testing requirement apply to? It applies to any provider of licensed migrant labor housing. So in Michigan, those who employ migrant farm workers and provide housing for 5 or more people, whether they're farm workers or not, are required to be licensed. So there are quite a few camps in the state of Michigan that are licensed by the state. And they're probably the easiest group for us to identify and to make sure are complying with this testing requirement. Also, this applied to those employers of 20 or more of the following categories: migrant and seasonal agricultural workers, meat, poultry, and egg processors, and greenhouse operations. Nurseries are part of the greenhouse operations, but there's not a direct overlap. So the point of the 20 or more is to target this to our biggest employers, but a lot of smaller employers do provide housing, and they were brought into it because of that. Since the mandatory requirement went into place, there have been a few ongoing issues and concerns. First, on October 3rd, the Michigan Supreme Court decided that the governor's authority to issue executive orders related to the coronavirus pandemic exceeded the authority within the state. However, this order was not an executive order by the governor. It was a public health order issued by the Director of Health and Human Services as part of the Public Health Code. So it was able to continue. Since then, we are moving forward to adopt new testing methods. The quick turnaround antigen tests are now being adopted for use with farm workers, and it promises something less invasive and a quicker turnaround. We're also looking and working to provide testing options at our welcome centers in southern Michigan so that agricultural workers on their way to a location can stop in at a welcome center and have testing done on the way up. A little bit like what Maine was talking about, but I'm really intrigued by their process. So we are looking to apply the lessons that we've learned in the testing area to the vaccination, and we're working with a lot of the same partners on that piece. But I will turn it over to Jackie for the next section. So I will stop sharing. Thank you.
All right, I'm going to unmute myself and get my slides going. All right, thank you so much, Dale, for giving a really great path of how we got to mandated testing in Michigan. I also have to give a really big thank you to Jose and Hannah and Lisa, because you set out some pretty big themes that I think are also very true for our experience in Michigan. So I think that this has been a really great panel time to kind of talk through a lot of these themes that we saw in 2020. And I think too, to reflect on a previous note made by a presenter, this is really a point of reflection for me here today, to kind of look back on 2020 and that process that Dale walked us through. I can't believe that we experienced all that in a short period of time, because I've been so focused on rolling out our vaccine efforts. So all of this that I'm going to kind of speak through today and walk through has entirely prepared us for how we're going to continue to roll out services in 2021. I think also to Dale's point, a lot of the testing work that happened really came about after the issuance of that public health order. And so accomplishing that level of baseline testing and responding to outbreaks and repeat testing, and also newly arriving workers for as we got into additional crop seasons and workers were coming to Michigan. We were doing a lot of this testing in a very short amount of time, which I'm going to walk through some of those numbers. But I don't think I actually introduced myself. I'm Jackie Chandler. I'm an integrated health program manager with the Michigan Primary Care Association. I'm going to try to give us a high level overview of what our health centers have been doing in Michigan. I also know that I'm joined here today by a few of our health center staff that actually contributed in a great degree to this work. And so I'm so happy that they're able to be present today. Okay, just a real quick, we are, as the PCA, the voice of our health centers. We have 45 community health centers around the state of Michigan and the upper and lower peninsula in both rural and urban settings. Actually, with recent UDS numbers, Michigan health centers serve more than 725,000 lives in Michigan, and at more than 300 clinic sites, which a lot of what we're talking today are actually mobile services that the health centers performed, which is not captured in that data that we'll be talking about today. And also that we are serving many community members beyond our established patient population. So I wanted to just give a little bit of time to acknowledge the history of farm worker health in Michigan. I think this is really critical. This is where we're kind of starting, and this is how 2020 has kind of changed things and where we've had funding opportunities to expand our outreach in Michigan. So I think, again, Dale spoke to this a little bit, but certainly in Michigan, sorry, I'm going to make sure I'm checking the chat as well in case there's any audio issues that I may have. I'm actually noticing that while I am presenting, I can't see the chat. So if you guys have any issues with if I'm going too fast or if you can't hear me, if someone could unmute and tell me, because I'm not able to see what's in the chat. So again, farm workers in Michigan are an essential workforce. We know that historically our migrant and seasonal farm workers have been critical in the planting, cultivating, harvesting, and packaging of more than 38 labor-intensive crops here in Michigan. And I also want to note that there have been migrant health centers in Michigan for over 50 years. Our oldest established migrant health center received their designation in 1968. So we have a long-standing history in Michigan. We currently have 5 migrant health center programs funded under 330G. And I've listed out those organizations on the map here. So you can kind of see where they are placed around the state. And then the next map that I'm going to bring up, I'm going to show you some of the breakdown of the MDARD migrant labor housing that Dale had mentioned. So you can kind of see how the bulk of that occupancy in Michigan aligns still very well with where our migrant health programs are. And then a little nod again to UDS from 2019. Health centers in Michigan serve nearly 14,000 migrant and seasonal farm workers with primary care. And I really just want to emphasize that 2020 CARES grant funding really created the opportunity to extend the reach of our health centers and to enhance mobile units, and to also bring in additional community health centers that haven't been able to connect as robustly with their farm worker community in their areas. So that's one of the silver linings of all of the funding that has come through that we were able to receive from our state and be a pass-through to our health centers to enhance and support their efforts. So I also really want to note that a big part of what Dale spoke about and what we've had previous presenters talk about with testing, we really needed to create access to low barrier testing services. This was before the mandate was published on August 3rd and has remained important even after the mandating of testing. So what we were able to do with that funding that we received, we were able to bring testing services out to work sites and camps, often coordinated with human resources. Of course, after the mandating of the testing, we were finding it was, there was a lot more opportunity to respond to the numerous requests that were coming through from employers and housing operators. And that we really worked to be mindful of the testing around shift work, to also expand out beyond traditional clinic hours to capture those early mornings or late evenings and also some of those weekend testing hours. We also had a streamlined registration form, so we were only asking for enough information to process the specimen at the lab. And what that means is we did not have to ask for any insurer information or information for the HRSA uninsured program, as we had sufficient grant funding to cover specimen collection and the cost of that test for those testing services we provided to this population. So there was no cost to the employer and there was no cost to the worker for a test performed by one of our health centers. I also really want to highlight, and of course I'll have it on another slide, all of our partners, but we had many partner service agencies that were accompanying our health centers and their testing teams that were also assisting with interpretation, testing event flow, ensuring folks understood where to appropriately safe distance themselves, and making sure that folks could move along the process for registration and specimen collection and any of the follow-up paperwork or other services that were being offered to workers. I do also want to note, and I think that this was previously noted, but because we were seeing so much volume in August and, actually beginning in July, but definitely August, seeing so many tests being performed on a week, we were learning just how tough it is. And I think we all know this in theory, but when you have your clinical folks that are entirely donned in PPE and doing a testing event in that more than 90-degree temperature in Michigan, and when our humidity index is really increased, that feels so much hotter, and having long testing events out in the field, we were learning about how that was starting to be considerations for, do you have the same testing team going out multiple days in a row, being able to switch out some of your staff so that they have a day of downtime in between. We certainly don't want to see heat stroke in our clinical providers either. And, also thinking about how we were scheduling events, and many of these events were, sometimes days back to back. So, certainly just something to be considering with all of that work that was going into this process. So I previously mentioned another map. I am actually including a map that is a dashboard that MDARD maintains, and is actually a really, really strong resource for Michigan in our testing efforts, but now with our vaccination efforts, and really trying to be mindful of where we might estimate need of our farm worker and food processing community. So I had noted previously our 5 migrant health centers, and that we were also able to extend funding to 4 additional health centers to also help out in some of these very high demand areas of Michigan that could extend the reach of our existing health centers. So this allowed us a more robust ability to respond to the requests that were coming through for the mandated testing. And I can say that in Michigan, we were able to reach more than 40 counties It was nearly 400 requests, which resulted in approximately 14,000 tests that were done in a mobile approach, and that this was over a 7-month period. But we were seeing the peak of most of that activity from about August through early October. So we have some large crop production in those months that really led to a lot of that testing, in addition to the baseline testing that needed to be accomplished. And again, I really just have to highlight, these are our partners. I know Dale was able to speak to them earlier, and the work with the community work groups, and how this has really been a process that we have had to find many points to pivot and address barriers or ways that might that we need to flag to advocate for to continue to bring vital services to our agricultural workers and food processing workers. So again, I just really have to highlight that it's an intense amount of coordination, the scheduling, the specimen collection, the resulting, the contact tracing, isolation housing, wrapping supportive services around that, which Audra's going to touch on in a few moments. This was only accomplished with the partnership, advocacy, and of course the funding to extend programs. And again, just wanting to note, I am listing an additional health center because we actually had a health center provide medical monitoring to a state-supported isolation housing at the YMCA Camp Pendaluan. So that actually brought us up to 10 health centers that were able to assist in this initiative. We had a huge amount of support from the governor's office, of course, MDHHS and their local offices. Of course, this had to be coordinated frequently with our local health departments, particularly with contact tracing. I'm realizing I put contract in there, and so that's supposed to be contact tracing, guys. And again, those 5 community action agencies, which Audra's going to speak a little bit about the support for that. And of course, our MDARD and our LEO staff that were supporting the outreach and the services in their areas. And of course, Michigan's standing interagency migrant services committee is a continuing and huge partner to any of the efforts that we accomplish here in Michigan. So again, this is a high-level look at our health centers and our partner agencies. I would have loved to put everybody's name on this slide. There have been so many that have contributed to our past efforts and our current efforts and our future efforts. So I just want to note again, all of this process, the history of this in Michigan, the things that we learned along the way that worked, that didn't work as well. This is all currently informing our current approach and our support for vaccination outreach for food processing and agricultural workers. So truly, the season's work is just beginning for us. March is starting to ramp up. We are having folks arriving and we are getting into our peak season. So we're in a much more informed and prepared position this year. The state continues to have the public health order in effect and continues to schedule to support that through another testing provider. And we are able to now pivot and really take a lot of time to support our health centers in their vaccination outreach and ensure that they can also continue to have mobile units that can reach workers where they are, whether that's at the work site, whether that's at their camp, or whether we are working with a organizational stakeholder in the community and making sure to have farm worker events in the community that can reach pockets of workers that may not be otherwise reached. So I am going to stop sharing and I'm going to hand it back over to Audra with Office of Migrant Affairs.
Thank you, Jackie. Hi, my name is Audra Fuentes. I am the Department Analyst for the Office of Migrant Affairs with Department of Health and Human Services. I am just looking for my PowerPoint to share. One moment. Okay, and I know we're close to time, so I'll be briefly covering our wraparound services that we had to offer for migrant and seasonal farm workers and agricultural workers. This is a service map of our MDHHS migrant program. We have 38 migrant program specialists throughout the Lower Peninsula, where the majority of our migrant and seasonal farm workers reside, where you've seen the other maps. They provide outreach and services to agricultural workers in 49 counties, and they provide public benefits and referrals to services. Public benefits include Medicaid, food assistance or SNAP, child care assistance, emergency assistance, and cash assistance. Dale and Jackie mentioned the work groups. They were very vital in this work. It was the local service providers that gathered and met weekly to identify the needs, provide updates of what each agency is doing, coordinate the testing, and then also reporting of agricultural workers who had tested positive through the testing efforts, and then coordinating service delivery to those positive workers. And that's the part I'm going to elaborate on. Again, this is a list of our work group members, and it was already reviewed what each member contributed to this effort. The wraparound services that we provided are PPE kits and housing cleaning products through donations through MDHHS directly, or through a community partner, or through the regional migrant resource councils that we have across the state as well. There were food baskets provided from the community action agencies, as well as through the Department of Labor had received donations. So positive workers were able to receive food baskets as well when they were isolating. And then we also had the isolation benefit through the CARES funds. So the isolation benefit through the CARES funds, that was developed to provide a financial support for agricultural workers who had to isolate. So it was available to those migrant and seasonal agricultural workers with orders to isolate from the local health department because they tested positive or because a family member tested positive. It provided for $500 per week for a maximum of 2 weeks for a total of $1,000. And it required them to follow the isolation orders in order to receive the payment, the second weekly payment. For the isolation benefit, the applications were taken by our DHHS migrant program specialists, and then processed by the 5 community action agencies that were set up through the Bureau of Community Action to be able to process these applications. There were forms of payment in either a check or in one area of the state, they also offered Walmart gift cards as well. It was very helpful for the farm workers that had to isolate. They were also notified of additional services through the federal sick pay and unemployment options as well, through information that was given out in packets. A survey of agricultural workers who received the isolation benefit said that they used the funds to purchase food, hygiene products, household products, and pay for rent and utilities as well. Another benefit that was set up through the mandatory testing that was approved the governor's office was an isolation housing set up at a YMCA camp that was not in operation last year for children. So the state contracted with them to have it as an option for farm workers and agricultural workers who needed to isolate and didn't have an option to isolate in the migrant camp where they were residing, could go to this camp. And transportation was provided to and from the camp. All meals were provided. They were, culturally related meals. There were on-site medical staff every day, 8 to 5, to assess their health and monitor their health. They were Spanish speaking as well. The housing was for single workers as well as families, and we had both that used the benefit. And through we had some use. It wasn't very widely used. We did find that there were growers and local supports for housing if workers needed to isolate. And so this is one benefit that we wouldn't have for this year because we're going to be resolving those issues locally. So our supports for COVID positive workers in 2021 would be the PPE and household items and food boxes still being provided for those workers who have to isolate. We don't currently have the isolation benefit unless it's renewed. The Bureau of Community Action has requested that, and we're hoping that becomes available. But since it was on the CARES funds that ended on February 15th, and then we'll have the local coordination of isolation housing. All right, are there any questions or comments?